Hello. This one's, I guess they're all different. But this one, I just want to show you a quick presentation this time because I thought it would be good to give an example. Because this is about ethics and doing the right thing, essentially. Understand and apply the ethical principles. The behaviour associated with it is that health chaplains will have a non-maleficence, do no harm attitude, be beneficent, seek well-being, respect autonomy, and be just. And I thought we need to put that into some sort of practical context. So I did my PhD on mental health nurse prescribing and ended up studying concordance. And the reason I did that was because it's one of the ethical tensions at the heart of mental health nursing. So there's a practical example at the end and a debate, and I'd like you to come out on the fence on one side or the other, having read all the evidence. So we'll start off with a quick definition of ethics, followed by a definition of concordance as opposed to adherence and compliance, and this is in medicine management. Quick look at why concordance is important, then why it fails, and then having a look. We won't bother with the 12 questions before dinner. But here's the ethical principles, and I always see them in tension. So you've got doing no harm, non-maleficence, against doing only good. Quite often they're in tension, and autonomy, doing, I guess, being an individual who is free to do whatever they choose within society is often opposed by society and its principles of justice. And so that's the way I see the four principles working together. And so they're often pulling each other out of shape and so on. So to get back to why I'm talking about this, compliance is seen as it's a paternalistic view. I don't think many would disagree with that now. The person is a passive party who is prescribed medicine, so they're just compliant. They just take their medicine as they're told. Adherence, to me, is not much more than that. It's still paternalistic because, in my view, the patient may be informed, but they have to stick with taking the recommended treatment. Now, my colleague Steve Hemingway disagrees with me on that, and he thinks that concordance can still happen here. This discussion can happen beforehand, and that's what I'd like you to think about at the end. Is that possible? And what are the consequences for healthcare chaplaincy? The ideal, to me, in medicine management is concordance, where you've got enlightened communication between the patient, the healthcare professional, leading to an agreed treatment and ongoing assessment of this as the optimal course. Partners in care, shared decision making, that's concordance. So it's also strategic priority, the quality strategy. The current strategy is all about shared decision making. So back in the quality strategy, it was about putting people at the heart of NHS Scotland. Those working in the health service will listen to people's views, gather information about their perceptions, and use that information to further improve care. So it's the right thing to do. It's a moral imperative. It's also the policy imperative. It's the ideal that we're trying to aim for. But it's also the psychological and physical imperative in that it actually is the best way of working. So shared decision-making must become the norm and not the exception. I know this is quite an old reference, but it still pertains now. The idea was to amend the Commissioner's duties to involve patients and carers in their own care to better reflect the principles of no decision about me without me. Remember that one? No decision about me without me? 10 years old now. And concordance itself, the agreement between patient and prescriber, is the best predictor of good medicine management, to the extent that people feel able to discuss their treatment preferences with the prescriber. And going back even further than that, to 1991, the best interventions, we've known this for a long time, empower patients to ask the most pertinent questions. In other words, an empowered, involved patient is more likely to ask the most pertinent questions about their treatment and hence be involved in it. And we know subsequently that people who self-manage are much better at taking care of themselves. So it's actually a fundamental good. However, there's a big gap between these ideals and practice, even though partnership working is fundamentally important. And some of these gaps stem from really valid concerns from the inherent complexities involved. So you might have been thinking to yourself earlier on, no, that's all very well and good, but how possible is that in practice? And any sort of policy attempt to push the involvement won't succeed, according to Cribb, and I agree with him, unless the practical and ethical challenges are explicitly addressed. And this is what Cribb meant by the practical and ethical challenges of concordance, and I think it applies more widely than that. So these are the practical and ethical challenges. The justification for shared decision-making is that it respects the autonomy of patients. It improves the decision quality, it enhances the effectiveness of the intervention, and shared decision-making thus allows the clinical expertise and patient values and preferences to be optimally combined to the best possible end. Now, against that, you don't really know who an autonomous patient is. My background's in mental health, so this was particularly tricky. Also, eliciting people's preferences is not straightforward. We know that people often say what they think they want the health professional to hear. And also, how do you handle people's preferences if they don't want to be involved? You can't force shared decision-making anyone. Involvement may be burdensome for some people. And involvement needs to be balanced against other considerations. Again, in mental health, such as, the level of decision-making capacity that individual may have. So it's not straightforward. Some people choose not to be autonomous. Quite a choice, but they do. And some people are not autonomous. Also, people's autonomous values are not necessarily self-coherent. We're not rational beings. And autonomy may be valued in discussing options, but might not necessarily extend to decision-making. And Della Cuevas was suggesting that he, as an expert, knows more about medicine than the patient does. And therefore, maybe there's a place for autonomy, maybe there's a place for shared decision-making, but perhaps not in the ultimate decision-making of what to prescribe. And so concordance doesn't have any place in these cases. And recognition of this will make the concept of shared decision-making clearer and hence much more achievable. Because if you don't address these issues, then you're not going to have a clear idea of exactly what it is that you're trying to achieve. More evidence against mental health nurses don't know as much about medicines as they think they do. That was the subsequent finding of my PhD. And therefore, competence is sometimes misaligned with confidence. Do have a look at the Kruger-Dunning law if you want to know more about that. It shows that those with the least amount of competence actually have the most confidence in their ability, which is a truly scary thought. We also know, from a practical perspective, that 50% of people don't take their medicines as prescribed or even as they think they are doing. And also, we've found that nurses, rather like my discussion on accurate shared decision-making, nurses think they're practicing concordance when they're not. They're actually just practicing adherence, just calling it something else. And I did find in a concept analysis that we did, we looked at the different ways that psychiatrists, psychologists, nurses and pharmacists all used concordance, the term, and they all used it differently. Okay, so there are also mismatches in important, well, I guess those are the mismatches in important attributes of prescribing. I've got a lovely graph somewhere of patients describing the most important elements of medicine management to them, and psychiatrists having a completely different set of values. So there's often a mismatch in patients and health professionals' views of medicine management. And I think that probably extends well beyond medicine management. And so, you can't have concordance until you've got a full, clear understanding between yourself and the patient. Solution. These are the 5 prerequisites for concordance in practice. And, they've been known a long time. And I think this is relevant for chaplains because I think it's perhaps more your field. A willingness to share power and commitment and to give appropriate weight to patient values and goals. I can't see chaplains having any problem with that, and it's really unfortunate that any other healthcare professional does. And you can have an open discussion of the options with explicit inquiry into the patient views without assumptions. Again, the problem from any healthcare practitioner's perspective is that they have an agenda. And if your agenda is just to elicit the patient's views on everything, then you don't. So I think chaplains are in a good position to be able to articulate this. Adequate share of information, including uncertainties, GDPR aside. Again, I think you're more likely to be able to share if you consider the other person capable and autonomous and able to hear doubt. And look at these two, listening as much as talking and time. So I just think that these 5 prerequisites, whilst ideal for every health professional, are perhaps not necessarily quite as achievable as they may be for chaplains. And that brings me on to the conclusion that I made about 10 years ago, which is really important for chaplains, because the notion of practical wisdom is entirely concordant with concordance because the focus is actually on the quality of the activity itself. In other words, you're more interested, more bothered about the engagement, the encounter, the being with the patient than you are about the outcome, which is the prescription. Whereas I would suggest that adherence-based interventions fail because they've got that the other way around. They've got so if you come in with an agenda, you can't achieve concordance, possibly not practical wisdom either. So that's the presentation. What I'd like you to do for this is to have a read of this paper that myself and Steve Hemingway wrote about 8 years ago. He argues for adherence and I argue for concordance. Now, this was in a nursing setting, but it'd be interesting to see what chaplains think about this. So what do you think about concordance? Is it possible for chaplains? Obviously outside of medicine management, but just have a read of this and see what you think. I'll be interested to hear your thoughts, and I look forward to reading some of those.